My name's Sandeep Chauhan. I'm a consultant orthopaedic surgeon down in Sussex, and I lead a team of 11 other NHS consultants and anaesthetists and physiotherapists in developing what is essentially a total surgery solution for pre-perioperative and recovery care for patients undergoing surgery. Next slide, please. So the solution has been chosen as part of the NHS Accelerator programme for 2021. In fact, we were the only surgical company to be chosen specifically to help hospitals recover from COVID. And so we're speaking to quite a lot of trusts, including trusts in London, around this. So restarting surgery encompasses quite a lot of things, as I'm sure a lot of you are aware, ranging from prehab, so that's all patients on waiting lists. We have over 5 million patients on the waiting list at the moment, delivering education to patients while they're waiting now. So it's not just the patient we're about to operate on, that's all the patients who are on the waiting list, because we can optimise for surgery. And that's a big focus from our joint college. The whole perioperative preparation programme, which is more than just a simple electronic questionnaire. It's around assessing their fitness for surgery, around consent preparation, e-consent, outcomes assessment, and then finally when they go home, monitoring recovery and preventing readmissions. As you're probably aware, the NHS readmits about 1 million patients within 30 days of each procedure, which costs us about £2.6 billion each year. Next slide, please. So we have a patient-centric solution which we developed over 3 years ago, now live in 10 hospitals and over 70,000 patients, which basically sits before and after EMR systems. So we're not trying to take over what an EMR does. It's a patient-facing system that allows patients to deliver information into a hospital and into an EMR system and enables hospitals to deliver information back out to hospitals. And it has 3 components: the secure virtual clinic, life box, and the recovery, which I'll show you shortly. Next slide, please. So EMRs historically have a poor patient-facing solutions. We know that, and it's not just us saying that as companies. We know that from our US work and from work speaking to colleagues in Exeter, for example, with Epic, from Newcastle, Oxford, Royal Free and Imperial. All the clinicians say the same thing, which is basically they are frustrated around the ability to communicate with patients and the limitations that EMR systems prevent them in getting patients ready for surgery. And clearly there is a cost to introducing new systems versus gains of efficiency. So, for example, in one North London trust, it takes them an hour per assessment and then 20 minutes to clean the room in between each patient. So there are real capacity issues that we face around what we can deliver in a surgical setting that we have to start releasing, and we need to look at different solutions. Next slide, please. So we have 3 parts of the platform: a secure virtual clinic, a patient assessment platform, and a recovery. Next slide, please. And everybody knows about secure virtual clinic, which is the top part of this diagram. We're not interested in the video part, but what we are interested in is the bottom part, which is what we developed. So we launched the first virtual fracture clinic in the country 11 years ago, won an NHS Innovation Award. And what we know from the data we have from that clinic, and has thousands of patients, is that whereas face-to-face patients only retain 60% of the information we give them, during virtual consultations, they retain less than 25%. And one of the key things digitally is by having a patient linked to a hospital via our system, we can send and receive information to the patient. So not just us as doctors, but the physiotherapists and nurses, the whole MDT team, so we can start changing that concept of care. So patients can deliver wound information or any other diabetic information to us, or any information you choose to look at, and we can deliver written or video information to the patient. Next slide, please. So we're not trying to become, I stress, an EMR, but this is an example, a PHR, but this is an example of a patient who went through a ICS pathway with a shoulder problem. I don't know if the video will play on this. If you click on the video, I don't know if it will play, but basically the patient uploaded their own video of their shoulder movement, which was them failing their recovery of treatment. So it showed us that they were actually not improving. They sent us a video of themselves, gave us their prescriptions. The physios tried physiotherapy with video tools, with physiotherapy, and it failed, and therefore they came to surgery. Next slide, please. When it came to surgery, they could then seamlessly go on in the platform to start complete their prehab, so their healthcare questionnaire, the preparation videos which are unique to that surgical procedure, and then their final assessments and surveys. They could do this all from the comfort of their own home, and all our patients now pretty much do this at home. Next slide, please. And one of the unique things about the healthcare questionnaire is the clinical validation process. That's hugely important for 2 reasons. The first reason is it improves standards of quality and consistency of our assessments. So actually every assessment done by every patient follows national guidance, which is what GIRFT wants. So Chris Snowden, who's the perioperative lead of GIRFT, is a huge fan of this, as is Tim Briggs. However, just as importantly, the clinical validation process we built in means that the information can actually be imported into an EMR, such as Epic or Cerner. Unless you validate information, EMRs won't allow you to integrate into their system, and we integrate via FHIR and have integrated into SAP, IPM, CyberLab, and a few others. There's numerous information that we can give hospitals around the validation process that nurses take. So, for example, in 3,000 patients, it takes less than 16 minutes on average to assess patients. So that's an incredibly short amount of time to produce consistent information. Next slide, please. The benefits of AV media are huge, and we've scientifically proven this. So going away from written information, again, delivering this into patients' home, so patients, carers, their extended families can all look at information. So this is one of the key things around Prehab. We're giving patients information in advance, well in advance, so that they're ready for surgery, they understand their surgery, and they have high satisfaction rates, and they can start their Prehab exercises or Prehab physio well in advance. Next slide, please. And the key thing is, I go back to, it's not just a single patient that we're just about to operate, it's all the patients on the waiting list. So, for example, at Wrightington, where we're established, we send all the patients on the waiting list the same bulk information that they get, and they then start looking at, irrespective of whether they're having their surgery in 6 months from now. So that's physio advice, getting fit for surgery, physiological advice, staying at home and isolation advice. Next slide, please. And the key is, when they've then had come into hospital, they've been through the EMR process and they've had their surgery and go home, we can continue to pick them up again. So via recovery, patients self-report their outcomes to us via smart dashboards. So we can reduce readmission rates and reduce outpatient appointments for follow-up, and we can improve communication. So reduce, for example, antibiotic prescriptions for wound infections. Next slide, please. So what we developed as NHS clinicians were smart patient-facing tools to change what is our traditional processes, and the majority of us trained in London-based teaching hospitals, and used our clinical knowledge to redesign and implement how processes work. Next slide, please. So in all the hospitals in the London area, this is a typical process for trying to get a patient into hospital. So the red arrow at the bottom shows you that basically a patient in a traditional EMR-based hospital will have to have an appointment and have their assessment done at that particular point. And at that particular point, whether it's face-to-face or via telephone, information starts to be gathered. The blue arrow to the left is how our system works. So it basically means that as soon as a patient is put on the waiting list, either new or existing, admin staff within the hospital or the ICS register the patient. So the patient is now delivering information and getting their information and their education very, very early, irrespective of when the actual interaction with the hospital occurs. And the effect of that is hospitals can prepare patients far, far quicker and far, far better and optimise them better. So, for example, during COVID, UCLPartners had 1,400 patients ready to go for when they restarted surgery. And what that meant for UCLPartners was essentially that they were the fastest recovering NHS trust in London. Next slide, please. Taking that one step further, instead of taking a single by single individual patient, you can take entire waiting lists, and you can start screening entire waiting lists. And because the patients are delivering that information in advance, as your hospital organisation starts recovering and your staff come back into the pre-assessment area, they can then start interacting at their own speed. And the key thing is that reduces cancellations, and it helps hospitals decide which site or, in fact, provider now patients are sent to. They get early sight of health risk. Next slide, please. Slightly complicated diagram. This is how it works in ICS. So in the top left, the patient's introduced via an ICS pathway. The top diagram, the top part of this diagram is the ICS pathway. The middle is surgery, and the bottom is recovery. The key is one platform follows the patient throughout the entire process. Next slide, please. And for networking, it means that hospitals, for example, UCLPartners, which work on 4 different sites, no longer have geographic constraints, because basically, based on NHS digital first and internet first policies, the hospital can decide where staff are based for their assessments on any particular day, based on staffing ratios and how staffing mix is working. Next slide, please. And just as importantly, patients can relay back information from geographic distance. They don't have to reattend, come into a large busy hospital if they don't need to, because we can monitor them pretty much straight away. Next slide, please. So what's the evidence and impact that this works? Next slide, please. So we're a digital exemplar on the NHSX playbook. This is the only one, in fact, on the NHSX playbook for any perioperative care programme. And you'll notice here that this study is based on Swellock. In 5,000 patients, we saved them over 3,000 outpatient appointments. We saved over £94,000 in cost savings. That's releasable cost savings in a year, and saved them over 2 hours of time per patient. Next slide, please. Again, scientifically, we proved this in a different hospital as well. So saved them over £90,000 of releasable costs, reduced POA times by 50%, reduced face-to-face appointments by 70%, improved coding, and identified more patient comorbidities than a GP summary did, because our changing demographics means patients are no longer going to their GPs because they're using digital online instead of going to their GPs now. And we had 0 on-day cancellation. So the theme was repeated again. Next slide, please. And improved prehab, which I showed you before. So we scientifically proved the prehab part of this. Next slide, please. And again, then showed that by early risk stratifying patients, the change in how quickly we see patients, so we don't wait for them to come to hospital, we see them earlier, we can start predicting their risk far, far earlier. And that correlates to subsequent risk in hospital. Next slide, please. And this case study from Wrightington, so Wrightington asked us to get involved with them after their first wave of COVID. They were decimated. The key part of this is they took that study one step further, and the effect of them early risk stratifying meant that they reduced their high risk clinics from 10 to 2 because they could effectively risk stratify, which is huge for them. It releases huge amounts of anaesthetic time and again a valuable resource that we need in theatre, not in clinics. Next slide, please. Patients are hugely satisfied by it. They enjoy doing it at home with a high net promoter score. Next slide, please. And that's the end. I realise I've rushed slightly, so I wasn't quite prepared to start early, but any questions, happy to ask them for you. But that's the entire end-to-end surgical journey.